That looks perfect. And so why don't I launch grand rounds for today? Here we are, the last day of January 31st. And I'm pleased to welcome Dr. Anant Mandawat to give medicine grand rounds for our department. Dr. Mandawat went to medical school at Yale. He did his residency at Massachusetts General Hospital and his training in cardiology and cardio-oncology at Duke. This is an area that I'm not at all familiar with, and was thrilled to learn about this area of expertise for him, where he is now here at Emory, the director of our Cardio-Oncology Center of Excellence and co-director of Emory's cardiac tumor program. He has a joint appointment in the Division of Cardiology and the Department of Hematology and Medical Oncology, and his research focuses on risk prediction of cardiovascular disease in patients with cancer. Dr. Mandawat, thank you so much for joining us today. He was willing to soldier through despite, having a cold and to give grand rounds. And I'm also very grateful for that. I'm very excited to hear about this area that I had no idea existed. So Dr. Mandawat, thanks.
Thanks so much, Wendy. Can you hear me okay?
Yeah, I can hear you perfectly and your slides look great.
Okay, great. Thanks. Well, thank you everyone for joining us today. I got a cold from my toddler, so I apologize. I might have to blow my nose or cough a couple of times, but the video's off, so you don't have the pleasure of seeing my rhinitis. But hopefully, if you have any questions, just you can raise your hand in the chat box, but we should have plenty of time in the end too for questions. But thank you again for joining us. Here are my disclosures. We have some research grants and funding from Pfizer, Myovent, and the Prostate Cancer Foundation, and I'll talk more about that towards the end. Thought I'd start off with a case. Mrs. R is a patient that I see in clinic. She's a 40-year-old female. She's an administrative assistant. She has a past medical history of hypertension, hyperlipidemia, and she's diagnosed with stage 3B, triple negative left-sided breast cancer. She's scheduled to receive neoadjuvant therapy with DDAC plus T, which is dose-dense adriamycin and Cytoxan plus Taxol. In the setting of receiving anthracyclines, a baseline echo was ordered. Let me loop this. So let me orient you here. This is supposed to be an apical 4-chamber view. This is her. Can you guys see my my pointer here? Let's see.
I thought we could a second ago. Here, show it to me again.
Let's see if I do it.
Yeah, there we can see it. Yep.
Okay. So this is the left ventricle here. This is the mitral valve. This is the left atrium. This is the right ventricle. This is supposed to be the tricuspid valve and right atrium. So here you can see at baseline, she has a normal left ventricular ejection fraction, and she has up here a trivial pericardial effusion. These are the 3D volumes of her heart. So this is using a single echo probe. We can cut the heart in multiple different views. And then trace here the end systolic and end diastolic volumes. And here you can see when we do that, she gives her an ejection fraction to start off with of 57%. So again, normal, which is good news. This is her strain imaging, and we'll talk more about strain imaging later, but you can think of it like an early warning system to detect cardiotoxicity. Her strain number here, and I'll go through more of this later, but hers is negative 19%, which is also in the normal range. So that's good. In interval, after her third cycle of AC, she presented with shortness of breath and edema. In that setting, a repeat echo was ordered. Here's what that looks like. So here again, this is her left ventricle, this is her mitral valve, this is her left atrium, right ventricle, tricuspid valve, right atrium. Here you can see she has a reduced left ventricular function. She also has bowing of her interatrial septum from her left to her right, indicating elevated left atrial pressures. These are 3D volumes now. So here again, tracing the end systolic and diastolic volumes, you get an ejection fraction of about 41%, so down from her baseline. This is her strain imaging now. So again, down from -19 down to -9. So all consistent with her picture of anthracycline-induced heart failure. So here's a question that I often see in clinic. You're consulted regarding the management of Mrs. R's heart failure. In particular, her oncologist wants to know how best to proceed with her cancer therapy while protecting her heart. Here's some choices. We should stop her AC. She shouldn't receive it again. Dose reduce additional cycles of her AC. Add cardioprotective medicines and consider restarting her AC, or recommend she be referred to palliative care. Let's give you a few seconds to think about it, then I'll go through it. So there's no easy answer here, right? I mean, you're stuck between a rock and a hard place, and that's really what cardio-oncology is about, right? On one side, you have her cancer prognosis, where she's going to need treatment, and you really want to offer her the best treatment. And on the other side, you have her cardiovascular disease, where if you push too hard, you're really going to cause problems there. And so it's this balance between how aggressively to push, when to back off, when to go forward. I think that's really hopefully what you'll see again in this talk, and kind of get a sense of the type of patients and how to approach them. So the objectives for today, first is to talk about the strong connection between cardiac disease and cancer. Number two is understand a clinical framework for approaching cardio-oncology. There's new cancer drugs that come out almost every week, and so it would be impossible to go through all of them. But really what I want to do is give you a framework on how to integrate cardiovascular disease and cancer, and you can apply that to really any drug that you see. We'll take that framework and apply it to anthracyclines, because regardless of who you are, you'll likely see patients who at some point have received anthracyclines. And then we'll also talk about strain imaging as a new imaging tool in cardiology for these patients. The last part of the talk will be future directions and special populations in cardio-oncology. We'll talk about immunotherapy. I talk about it as the new kid on the block, but it's actually so widely used now. You're going to see it again and again. And then I'll talk to you about some of the research that we're doing in prostate cancer. So the way I designed this talk is really cardio-oncology. The evidence for it changes, it seems like almost every month, and it really is very cutting edge. And so I think it challenges a lot of the paradigms that we learned about cardiac care in cancer patients from our training, even from my training. And in that sense, the way I designed this is I'm going to present those paradigms to you, and then I'm going to present arguments that hopefully refute it and really try to convince you that we've entered a new era or new frontier of cardiac care in cancer patients. So let's start off with that. This is something actually I overheard in the emergency room. Cancer patients are not going to do well anyway. We don't need to worry about their heart health. So let's talk about that one. Let's look at the epidemiology of cancer and cardiac disease. So these are the top 10 causes of death in the US. This is an awards list you don't want to be on, but consistently heart disease and cancer are number 1 and number 2 in both males and females. I think the other thing that's striking about this chart is how much heart disease and cancer overshadow the number 3 through 10 causes of death. So again, regardless of who you are, a cardiologist, an oncologist, a general practitioner, invariably you're going to see patients that come at the intersection of these two diseases. This is a chart of innovative compounds in phase 1 through 3 development over the last 2 decades. And really what stands out here is the line in light blue, and that really is oncology drugs. There's been a dramatic increase in these drugs, and you're probably seeing this in clinic on drugs that really we haven't trained on before that our patients are on now. This has led to dramatic improvements in survival rates for many of the common cancers. This is data from SEER from the 1970s to the 2010s, looking at breast, lung, prostate, colon, bladder, all of them having improvements in survival. And that's caused an increase in the number of cancer survivors. So this is in the 1970s, there was about 4 million. In 2016, over 15 million. In 2040, expected to be over 26 million. So by any metric you use, we're doing better and better in caring for cancer patients. And the real question now is, how do we push that needle even further? And how do we do even better for these patients? One way to look at that is to look at the top non-cancer causes of death in cancer patients. And again, here's this data. This is from SEER from the 1970s to the 2010s. And really what stands out to you here is in red. This is cardiovascular disease. Cardiovascular disease traditionally, if you look at this chart, was something we thought affected patients potentially 5 years or so, 10 years or so down the line from cancer diagnoses. But you can see here, immediately after diagnosis, this is something that has a big impact for our patients. So ultimately, what are we trying to do in cardio-oncology? We're really trying to shift this curve. This is data from Kaiser Permanente linked to SEER of over 36,000 cancer survivors. What you could, it's X on the X-axis is follow-up in years, and the Y is survival. And what you can see here is the line in red, cancer survivors with cardiovascular disease really have the worst survival out of any group. And what we're trying to do in cardio-oncology is really move them up this curve, up from the red line up to the gray line, and as a result, make a big difference in their lives and improve their outcomes. So going back to this statement, cancer patients are not going to do well anyway. We don't need to worry about their heart health. Hopefully I showed you this is a myth. Due to innovations in cancer therapy, survival from cancer has improved. Cardiovascular disease is a leading cause of morbidity and mortality in cancer patients, and the prevention and treatment of cardiovascular disease improves outcomes in cancer patients. So let's switch gears and talk about a framework on how to approach patients in cardio-oncology. So let's tackle another paradigm to do that. So cardiac issues in cancer patients is a down the road kind of problem. Let's get them through their cancer treatment, and we can worry about the heart later. So to look at that, let's talk about an overview of the different type of cancer therapies. So in the 1950s, cytotoxic therapies were introduced. So these are drugs that target the cell cycle. And the idea here is with drugs like vincristine, methotrexate, cancer cells divide more rapidly. So these drugs would preferentially target cancer cells. As we know, these drugs are associated with a whole range of other side effects, including that on the heart. In the 1990s, targeted therapies were introduced. So these are drugs like Herceptin or trastuzumab that target the HER2 receptor, or bevacizumab that target the VEGF receptor, primarily monoclonal antibodies. But as we know, these drugs can also have cardiac side effects too. Lastly, in the 2010s, immunotherapy was introduced. This is the idea that we activate the immune system to go fight cancer cells. But as you can see from the inlay, and we'll talk more about it later, is that when these activated cells cross-react against cardiac myocytes, the consequences can be quite devastating. So ultimately, when cardiotoxicity develops, what does that look like? Well, the poster child for cardiotoxicity are really anthracyclines, and we'll talk more about that later in this talk. And that causes cardiomyocyte damage and heart failure. One of the reasons I like this figure is it really shows you how broad the spectrum of cardiotoxicity can be. It can be heart failure, hypertension, coronary disease, valvular disease, pericardial disease, arrhythmias. And so there's a whole range of drugs. This slide's from 2016, and that number has just expanded rapidly since then. And it's really about knowing all the different aspects of cardiac care that I think makes this field very fascinating. I think the other thing in this chart you'll see is that the effects of the toxicities that we see are both acute and chronic. Anthracyclines can do both. As you saw Mrs. R, and I'll talk more about later, it can be an acute or chronic effect. Hypertension is certainly acute. Coronary vasospasm from 5-FU, for instance, is also acute. Valvular disease often is more chronic, so is pericardial disease. But really, it's something that can have short-term or long-term impacts on patients. I think the last thing in this slide you'll see is that it really takes a team-based approach to treat these patients. You know, we need good colleagues in interventional and in EP and structural that really understand not only what the drug is, what it can do, but also how to walk that line carefully, because again, everything we do in these patients can have implications for their cancer therapy. So it's really important to be thoughtful in that. And we're lucky we have those kinds of teams at Emory. So putting all of this together, this may be the most important slide of this talk. So this is the idea of this competing therapeutic dynamic of cancer and cardiovascular disease. And what do I mean by that? So in cancer treatment, the goal is really to starve, target, or destroy malignant cells. We really throw the kitchen sink at patients at times to be able to do this, right? From cytotoxic to targeted to immunotherapy. Anything we can do to kind of kill these cancer cells is where we go. In contrast, when you think about heart disease, the goal is really to nourish, heal, or protect cardiac myocytes. I mean, when you think about a STEMI, for instance, right, when someone comes in, the first thing we do is we try to take them to the cath lab, put in a stent to increase blood flow in these patients. And so this is kind of a yin and a yang that you're going to see time and time again, even from the case we saw in the beginning. Putting that all together, I mean, take a drug like VEGF inhibitors. VEGF inhibitors function by inhibiting angiogenesis, so they cut off blood supply to the tumor. But you can imagine any drug that does that, as you can see on the bottom of the slide, it can have consequences in the form of cardiotoxicity, and we see that in clinic. And so again, it's this yin and yang, this idea of when do you want to put your foot on the gas and when do you want to take it off? That's really what a lot of this field is about, and trying to understand both the drug, the oncologic prognosis, the cardiac prognosis, and how do we best balance all of that. Ultimately, if someone develops cardiac toxicity, what is the implications for the patient? And it can really be devastating. It can result in interruption or discontinuation of their cancer therapy, and we know that that's associated with worse outcomes for the patient. There's the physical morbidity and mortality of cardiovascular disease, and this audience particularly is very familiar with that. There's a psychological impact of an additional severe comorbidity. It really is a gut punch for these patients when you think about it, right? They got a diagnosis of cancer, they got to wrap their head around that. Then they agree to take all these toxic therapies that cause them to feel horrible. And then, by the way, they're told that those therapies have impacted their heart and they have to stop their therapy, and they don't know if their heart function is going to get better. And so we spend a lot of time in clinic really talking to patients about this and comforting them that, hey, we've seen these before. We know these drugs. We've gotten other patients through them, and we'll get you through them as well. Lastly, we're not as familiar of this in cardiology, but for a lot of cancer patients, their clinical trials are really their last lifeline. They've gone through first line, second line, third line, et cetera, and these clinical trials are what's keeping them alive. Unfortunately, cardiovascular disease is often a disqualification for patients from these trials. So it's really important both to be proactive in trying to prevent cardiovascular disease, but also if it occurs, if they develop toxicities, to be very quick in being able to evaluate and treat those. So going back to this statement, cardiac issues in cancer patients is a down the road kind of problem. Let's get them through their cancer treatment and we can worry about the heart later. Hopefully I showed you that this is a myth. There's a competing therapeutic dynamic between cancer and cardiovascular disease, placing the heart at risk. Many cancer therapeutics are associated with acute cardiac damage. We talked about things like 5-FU and VEGF inhibitors. And then the implications of cardiac toxicity includes interruption or discontinuation of cancer therapy and worse patient outcomes. So what exactly is cardio-oncology? I kind of went around it for a while, but giving it a definition is really, these are providers that have specialized knowledge of both cardiac disease and cancer that come together with really three goals. First is to maximize cancer treatment. Number two is to minimize cardiovascular toxicity. And the third is to really improve overall outcomes for patients. How do we do that? How do we take that to the patient at the bedside? So here's one way to do it in an integrated approach of cardiovascular disease and cancer. So all patients after a cancer diagnosis, they have a baseline level of cardiovascular health. For that patient, that's their 100% cardiovascular reserve. As they go through their cancer treatment, invariably, there's going to be some level of cardiovascular insult, and that may drop their reserve down from 100 to 75%. They don't have any structural heart disease at this time, but they may have something called subclinical dysfunction. Ultimately, if that damage continues, they'll develop structural heart disease, and this is a form of an EF decline. And ultimately, if that progresses, they'll develop clinical symptoms of heart failure that we're familiar with, and that can result to premature death. Where are areas that we can help these patients? So first of all, we can see these patients before they start their therapies to really optimize their cardiovascular reserve. So these are things like risk factors, comorbidities that we know that are particularly targeted by the drugs that they're going to be taking. Number two is once we know the type of drug they're on, we can develop a tailored monitoring plan for them. So for instance, Herceptin or Anthracyclines or VEGF inhibitors all have different effects. And so knowing what to look for there. If they develop any level of subclinical dysfunction, so in the form of strain imaging, which we'll talk about, we can intervene with cardioprotective medicines early. And certainly if they have a drop in ejection fraction or they develop clinical symptoms, this is areas that we should be seeing these patients. Ultimately, the idea here is the earlier we see these patients, the better chance we can recover their cardiac function, and the better chance we can recover their function, the better they can do, and the longer they can stay on their therapy that can help with their cancer. 10 years ago or so, I would say the majority of patients that we were seeing were really on stage 4 and stage 5 at the point where damage had already occurred. And really what we've done at Emory over the last 5 years is focus on seeing patients before and during therapy. And really by doing that, allowing our oncologists to go bigger and bolder in the type of therapies they're able to offer, knowing that we're working hand in hand with them to protect cardiac function in these patients. So let's take that approach and apply it to anthracyclines. Here's another statement. Anthracyclines don't cause damage unless they're over a certain threshold. This was actually on cardiology board review books, so I thought this would be a good one to tackle. So let's talk about anthracyclines. So they were discovered from the fungi Streptomyces. From medical school, you remember they function by inhibition of topoisomerase 1 and 2. And they've been used in clinical oncology starting in the 1960s, so they've been around for a while. They're effective in treating a wide variety of cancers, including breast, lung, leukemia, lymphoma, sarcoma, so much so that they're on the World Health Organization's list of essential medications. Now, we've known about cardiotoxicity from anthracyclines for a while as well. This is the first case series that was published out of Baylor and MD Anderson in the 1970s of 399 patients. They found 11 cases of adriamycin-induced cardiotoxicity, including this 24-year-old female with osteogenic sarcoma. On the left is her chest X-ray at baseline, and on right is her chest X-ray and florid heart failure after anthracyclines. They found only one case of toxicity when the dose was less than 550 milligrams per meter squared, and therefore the recommendation at the time was to limit dose to this cutoff, or 550. Now, echo wasn't widely available in the 1970s, so that 550 cutoff was largely based on clinical symptoms. So Swain and colleagues in 2003 studied the rate of heart failure using echo in 630 patients with breast and lung cancer who received doxorubicin. And this is the main figure from their paper. What they found was that doxorubicin-related heart failure occurred at a lower dose, so now dropping from 550 to 400, and with greater frequency than previously thought of from the 1970s, which makes sense because echo was likely a more sensitive tool. So we dropped the cutoff, so now from 550 to 400, but could it be that the threshold was even lower? It's just that we didn't follow these patients out long enough. So to test that, Mulrooney and colleagues studied 14,000 survivors of childhood cancer. And what they found was with longer follow-up, the threshold for cardiac toxicity was even lower at now 250 milligrams per meter squared. And this really solidified a theme for anthracyclines that cumulative dose, even at small doses, can cause cardiac damage. So putting that all together, this is the latest figure from the ASCO educational book. You have cumulative anthracycline dose on the x-axis and odds ratio of cardiomyopathy on the y-axis. And what you can see here is after this 250 cutoff, the odds ratio really increases dramatically. So it goes from 7 to 23 to 27 plus. So clearly after that cutoff, things look worse. I think what's even more interesting here is really this part of the curve, where it's suggesting that even with a single dose of anthracyclines, the risk of cardiomyopathy increases by 65%. And so again, going back to this idea, this yin and yang about a lot of the drugs that we're using in cancer treatment, is that they're essential, right? They're essential in treating disease, but we also have to understand they're an essential poison that at times, if we overuse it, can hurt the heart. And we need to be very careful about being able to monitor and assess cardiac function and intervene and protect the heart when it's needed. So recognizing this, are there patients that are at increased risk for developing cardiotoxicity? So this is a guideline statement released by ASCO in 2018. And these are the patients they felt were at highest risk. So high dose anthracycline. So again, this cutoff of 250 milligrams that you saw from the Mulrooney paper. High dose radiotherapy with the heart in the treatment field. low-dose anthracyclines and low-dose radiotherapy, or low-dose anthracyclines with trastuzumab sequentially, so kind of this two-hit hypothesis. And lastly, lower dose anthracycline or trastuzumab alone. And any of the following: multiple cardiovascular risk factors, older age, or compromised cardiovascular function. And one of the ones that stood out to me there is this kind of borderline low EF. In cardiology, particularly, we see a lot of patients that have a borderline low EF, this 50-55 that we kind of brush off. And I think in this patient population, it's even more important to keep track of these patients. So we have clinical criteria. There are imaging tools we could use as well. So there certainly are. So this is where the idea of myocardial strain imaging comes into play. So what exactly is it? So strain imaging is possible because ultrasound waves from echocardiography form a unique interference pattern for each myocardial segment. These patterns or speckles, you can think of them as kind of acoustic fingerprints for different segments of the myocardium. They're tracked throughout the cardiac cycle, and these segments are analyzed for a change in size or deformation. The deformation values are averaged, and that's what's produced a number that's called your global longitudinal strain, or GLS. The higher the absolute number of GLS, the better the LV function. So you saw that in Mrs. R. She started off at -19, which is better than her subsequent one, which was -9. So what does that look like on the echo machine when you have that output? So this is the echo machine tracking. This is the software tracking the myocardial segments throughout the cardiac cycle. This is the apical 4-chamber view. We capture this in the apical 4, apical 3, apical 2, and then we average all of that together ultimately to generate this, which is called your bullseye plot. This is Mrs. R's baseline bullseye. So you can see here the computer's assessing it in different views, and then it gives you an average number here at the bottom. So hers is normal here, -19. Is there evidence that suggests that strain imaging can help our patients? So there certainly is. This is the SUCOR trial that was published in JACC in 2021. And the question they asked is strain-guided initiation of cardioprotective medications better than an EF-guided initiation? This was an international multi-center prospective randomized trial of 331 anthracycline-treated patients with a median follow-up of 1 year. And what they found was in the strain arm, less patients had cardiotoxicity compared to the EF arm, which was good. And then among those with cardiotoxicity, the strain arm had a higher EF at follow-up compared to the straight EF arm. So in other words, we found it more, we helped patients more, and then in those that we found it, we were likely able to initiate therapy earlier for these patients, and so they ended up with better function. So good evidence to suggest that strain imaging can be very helpful for our patients, and it's certainly something that we do here at Emory for our cancer patients. So going back to this statement, anthracyclines don't cause damage unless they're over a certain threshold. Hopefully I showed you this is a myth. Anthracyclines are a versatile chemotherapeutic agent effective against cancer. However, they're also an essential poison that increases the risk of cardiac damage, even at low doses. Risk factor modification in cancer patients is important in decreasing cardiovascular events. We talked about the importance of the cardiovascular reserve. And the detection and action on subclinical dysfunction using GLS results in better outcomes for patients. And I showed you data from the SUCOR trial for that. Taking on another statement, this is actually sometimes I hear from cardiology fellows that, okay, Dr. Mandawat, I mean, you do all these things and you presented all this data, but we can't do anything for these patients. So why are we going down this road? So let's talk about that. So this is really the million-dollar question, right? So is anthracycline cardiotoxicity reversible or not? This was a schema that was developed out of MD Anderson by Uhr and Lipman in 2005, and they broke down cardiotoxicity into 2 different types. They called type 1 damage, where the characteristic agent was doxorubicin. And they felt that the underlying damage appears to be permanent and irreversible. And in contrast, there were drugs like trastuzumab, which are HER2 agents, that was felt to be reversible. So this schema is now become defunct, and let's talk about why that's the case. And so to understand that, you really have to understand the timing of anthracycline damage. So there's 3 phases of anthracycline damage. There's an acute phase that can happen over days. There's a subacute phase that can happen over months. And then there's a chronic phase that can happen over the years. And traditionally, that's where most providers saw these patients, right? Patients got anthracyclines many years ago, and then they come into someone's office, they're short of breath, and someone gets an echo and the EF is down, and we say, oh no, what this was likely from the anthracycline many years ago. But when does the damage actually happen? So Cardinale and colleagues looked at this, and they showed that 98% of the damage actually occurred within this green box, which is the first year after therapy. So what if we identified and treated toxicity early, where was it within this green box? Could it actually be reversible? So the answer is yes. This is a study of patients who received anthracyclines and developed heart failure. The researchers examined the relationship between the time from anthracycline administration to the start of heart failure therapy. And what they found was that those who started on heart failure therapy within 6 months really had the best chance of improvement. So getting to the idea of this time to toxicity detection and time to toxicity treatment is really key in cardio-oncology patients. The American Heart Association also recognized this, and they developed a guideline statement to look at monitoring in these patients. Here's a figure from that statement. And if you look at the top row here for anthracycline therapy, essentially all patients receive a baseline echo. It's pretty much standard of care. You can't really give anthracycline therapy now without that. I think what's interesting is if you look at post-therapy, they're recommending an evaluation at the completion of therapy, as well as that magical 6-month cutoff that I showed you. Because again, if we catch them within that time period, that's where you get the best chance of reversing any damage that could have occurred. Is there anything we can do to prevent the damage in the first place? So there certainly is. So this is a drug called dexaroxane. It's an iron chelator. This is a Cochrane review of over 1,500 patients. And you can see here an odds ratio of 0.18 in favor of prevention of clinical heart failure with this drug in anthracycline patients. So certainly a drug that is available. I would argue it's probably underutilized, but something that is out there that particularly in higher risk patients, we potentially should be using more to help them. So going back to this statement, we can't do anything for cardiotoxicity. Hopefully I showed you that this is a myth. Cardiac toxicity can be reversible. Anthracycline damage usually occurs within the first year of therapy. Time to toxicity detection is key, with earlier detection increasing the chance of recovery. And understanding the importance of early detection, the American Heart Association has developed screening guidelines for anthracycline toxicity. And dexaroxane is an effective tool to prevent anthracycline toxicity. Let's switch gears and talk about immunotherapy. So here's another statement. These new immunotherapy drugs are so difficult to pronounce. That is the truth. Hopefully that got a little bit of chuckle out of you. This is Jimmy Carter. He had metastatic melanoma to the liver and brain, and he was treated at Winship with radiation and an immune checkpoint inhibitor called pembrolizumab. In 2015, it was announced he was cancer-free after an MRI didn't show any signs of his original disease. This is Hanjo and Allison. In 2018, they were awarded the Nobel Prize for their work in cancer immunotherapy. So what is immunotherapy? So these are drugs that result in T cell activation. They work by removing inhibitory immune checkpoints, so things like CTLA4, PD1, PD-L1, and therefore restore the anti-tumor response. You can see from the inlay here, one of the problems is that activated T cells can also cause damage to cardiac myocytes. And again, this concept of this competing therapeutic dynamic, it's going to be throughout a lot of the drugs that are used. Thankfully, as far as side effects go of immunotherapy, myocarditis is not the most frequent. It's usually colitis, but unfortunately, when it occurs, the fatality rate can be up to 40%. So it is one of the most feared complications of immunotherapy. How does it present? So this is a case series that was published in the New England Journal as a postmortem. It usually presents with heart failure, malignant arrhythmias, and then rapidly progressive shock and death. These are stainings that show that cardiac tissue was positive for CD3 positive T cells and CD8 positive T cells, and was negative for B cells. So again, confirming that this is likely a T cell driven phenomenon by activation of immune checkpoint inhibitors. Often myocarditis can be a difficult diagnosis to make. So what tools do we have for that? So really we have our traditional tools. We have EKG, troponin, proBNP, and EF. And this was a case series that was published in JACC in 2018. I think what's interesting here is that, oftentimes when these patients come in, they're short of breath, they may have some lower extremity edema, presenting with heart failure. We often get an echo and we say, oh, well, the ejection fraction is normal. It can't be myocarditis. It can't be anything that bad. If you see here at presentation, more than half patients had a ejection fraction of 50% or more at diagnosis. And so really something that it's important to keep a high index of suspicion for in these patients. Ultimately recognizing that, we teamed up with Tom Nealon out of Mass General and many other centers to form an international cardio-oncology registry. And one of the questions we wanted to look at was the association of strain imaging with major adverse cardiac events in ICI myocarditis. This was a retrospective case control of GLS and ICI myocarditis versus ICI without myocarditis. And what we found was reduced strain was associated with an increased risk of MACE in patients with both reduced and preserved EF. So potentially strain can be a useful tool in these patients as a tiebreaker to help assess, even if they have a normal or reduced EF, that are these patients we need to keep a higher index of suspicion for. Another study we did out of the registry was the relationship of steroid dose and timing to MACE, again, a retrospective study of 126 patients. And what we found was that high dose steroids and an earlier time from admission to steroid initiation was associated with lower MACE. So again, this concept of time to toxicity detection and time to toxicity treatment is really important, not just in the anthracycline population, which I showed you, but also in the immunotherapy population as well. Thankfully, recognizing the really high fatality rate associated with this, more studies have been done, and we have more tools now to treat ICI myocarditis. We now have CD52 inhibitors and CTLA4 agonists, often used in refractory myocarditis. They have very dramatic results and can really melt away that inflammatory response and really save these patients. So putting it all together, what is the treatment algorithm for ICI myocarditis? So the first step is to certainly discontinue the immune checkpoint inhibitor, give high-dose steroids early, and I showed you data for that. We can add CellCept, CTLA4 agonists, or IVIG, or other immunomodulators ultimately to try to control it. You can consider a biopsy. There's some centers that biopsy all patients. There's some centers that biopsy no patients, and we really take a more personalized approach in the setting that do we think it's going to affect their long-term care. And if we do, then we go after it. If not, then we treat it empirically. Ultimately, this is also one of the key teaching points is that we've seen patients before who've been referred to us. They were diagnosed with ICI myocarditis, started on steroids appropriately, but unfortunately their steroids were tapered too rapidly. And sometimes that can cause the myocarditis to flare back up to an even worse level. And so it's really important to slowly taper these steroids and often monitor them every time you step down on the steroids as well. So going to the last part of the talk, kind of future directions, let's talk about prostate cancer and cardiovascular disease and some of the work we're doing there. Excuse me. So prostate cancer is the most common malignancy in men, accounting for 20% of incident cancers. Among prostate cancer patients, cardiovascular disease is really a leading cause of death, largely felt to be from what's called androgen deprivation therapy, or ADT. Complications can include higher rates of heart attacks, cardiomyopathy, hypertension, stroke, and arrhythmias. What exactly is ADT? So ADT is the mainstay treatment of prostate cancer in the US. Over 400,000 men receive it every year. And the most common form is what's called gonadotropin releasing hormone agonists, or GnRH agonists, and it's typically administered every 3 to 6 months. There's 3 randomized trials that have shown improved outcomes when ADT is added to radiation therapy for patients with prostate cancer, and it can be given for between 3 to 36 months, and it's first-line therapy for metastatic cancer that can be given lifelong. There's a strong link between androgen deprivation therapy and cardiovascular disease. It can lead to worsening metabolic derangements. It can lead to increased cardiovascular events, largely based on epidemiologic data. This risk can increase even as soon as 3 months after starting ADT. This data was so compelling that it actually led to a joint scientific advisory statement issued by the American Heart Association and the American Urologic Association. And that prompted the FDA to add cardiovascular event safety information to GnRH agonists. So putting all of this together, prostate cancer is very common. It's often treated with ADT, but ADT is associated with worse cardiovascular events. However, in all of this, you're certainly lacking tools for cardiovascular risk stratification in this population, which is critical to improving their outcomes. So to help with that, we teamed up. This is Dr. Sagar Patel in radiation oncology, and this is Brian Olson in immunology. And what we developed was called a cardio-oncology prostate cancer biobank. What we're doing in these patients is collecting blood both prior to ADT start and then multiple times while they're on ADT therapy. And really, our mission is to understand mechanisms and identify early biomarkers of cardiovascular toxicity in men with prostate cancer undergoing ADT therapy. We think a lot of this is driven by the immune system. It turns out that T cells actually have GnRH receptors on their surfaces. And when GnRH agonists bind to this, T cells can enter plaques. And when they enter the plaques, it can result in chronic inflammation, plaque instability, early rupture, and potentially early cardiovascular events. So our hypothesis is that elevated frequencies of T cell populations are associated with increased development of cardiotoxicity in patients receiving ADT. Ultimately, our goal with the CoPro Biobank is really a comprehensive phenotyping to help identify markers associated with increased risk of development of cardiotoxicity. So we're working on the immune angle currently. We're working on a genomics angle, looking at CHIP alterations, which is a new series of alterations that's associated with inflammation. We have proteomics work going on, and we actually have prelim data, which would be the first ever to show that epidemiologic data that shows that within 3 months, we're seeing proteomic changes in these patients as well. So that's our goal, really, to give us a comprehensive profile of what's happening in these patients and what's driving cardiovascular disease for them. So putting this all together, just some conclusions for the talk. There's a growing population of cancer patients, and improving the burden of cardiovascular disease is critical to improving their outcomes. There's this competing therapeutic dynamic between cancer treatment and cardiac health. Cardiac toxicity, including anthracycline damage, can be reversible. Early detection and early treatment are key to reversing damage. Immune checkpoint inhibitor myocarditis is associated with high mortality. Early treatment with high-dose steroids is indicated. And lastly, ADT in prostate cancer patients is associated with a high rate of cardiovascular events. Tools for cardiovascular risk stratification, hopefully from CoPro or other biobanks, will be critical to improving outcomes in cancer patients. Thank you for your time. I really appreciate you guys having me, and I'd be happy to take any questions.
Thanks so much. That was a really informative talk. I think several of us were texting back and forth about things we were learning as you were talking. One question, the first question that was in the chat from Dr. Ray, and it echoes a question that I had, which is, you definitely made the case that detecting cardiotoxicity early makes a difference, but curious, even a step before that on the cardioprotective side. And you mentioned dexrazoxane and that it's underutilized. Why isn't everybody that goes on an anthracycline on that drug? And are there other, sort of cardioprotective upstream things that can be done other than just simple risk factor modification?
Yeah, absolutely. So dexrazoxane's story is actually interesting. Dexrazoxane, when it came out, actually had really good, was received really well in the oncology community as a drug that could help patients. Unfortunately, there were association studies that were done after that suggested that in some patients, dexrazoxane could reduce the efficacy of anthracyclines. And that got picked up, I think, potentially with a little more steam than it should have in the community. And for that reason, it's often not given potentially to the level that it could be given. The second reason for that is also dexrazoxane, at least from an FDA approval level and a payment level, is only approved at anthracycline doses greater than 300 milligrams per meter squared. So that's a little bit behind the times with the data that I showed you. But again, getting approval for that may be tricky in patients who've never received anthracyclines before. If it was my family member, I certainly would want to consider using dexrazoxane, because really the evidence is there now that there's enough patients that we've looked at that shows that it can have a really good effect for them. Getting it approved from an insurance standpoint may be another test in the whole system, though.
It's always the insurance, right? And related, what's from the Midtown group, what's the mechanism for its protective effect on anthracycline toxicity?
Yeah, people have tried to look at this as well. It's largely felt to be it works as an iron chelator, and it's felt to be that iron functions by binding with the drug. And that is what induces some of the effect on topoisomerase 1 and 2. There's other theories for it. It's felt to be reduced reactive oxygen species, and there's several New England Journal reviews on this and that. But it looks like the most pronounced effect is related to iron. So if you can scavenge out the iron, it seems to reduce the cardiotoxic effects. Um, Anthracyclines work on inhibiting two kinds of topoisomerase. There's a topoisomerase 2 alpha and a beta. And it looks like that although it can inhibit the beta, which then assists with the cardioprotective effects, it doesn't affect the other subunit. And so for that reason, it doesn't look like it affects efficacy of the drug.
That's really interesting. All right. From Abigail, two questions. Can you talk about how echo, many of your studies were looking at following or detecting early cardiotoxicity with echo. Can you address how echo is a blunt tool for measuring EF and what specific heart failure meds have been tested in chemo-induced LV dysfunction?
Yeah, great questions, Abby. So echo by itself, as many people who read echo can understand, is that echo has a certain amount of variability in its interpretation. That variability has been a source of criticism as to definitions of cardiotoxicity. And I didn't go into it in this talk, but definitions can be variable depending on the society that you use to define cardiotoxicity, whether it's an oncology society or a cardiac society. One of the ways that 2D echo has certainly been ripe with this criticism, and there's evidence out there that suggests that the inter-reader variability is certainly enough there that perhaps it shouldn't be the go-to tool for these patients. The evidence also suggests now that 3D echo is potentially a better tool. And so this is the idea that, again, I showed you some images where you can cut the heart in multiple segments, you can visualize it better. And then in that setting, you can get a more consistent ejection fraction. So it is recommended now that for oncology patients, whenever possible, whenever the imaging quality is available, that we use 3D echo. The other aspect in that is also there's been a push to potentially use cardiac MRI in these patients because obviously that has a more consistent readout. And the last one is that we previously used MUGA studies in these patients. So the idea that you can reproduce an ejection fraction there. There's two downsides to both of those. The cardiac MRI, although attractive, it certainly is more laborious for the patient to be able to do that, to go sit in the scanner, schedule time on the scanner, be able to do all of this. We do use it in some patients. So patients, for instance, that have a readout of, let's say, 40% or something right on the borderline to use some of these drugs. If we're not convinced and the clinical trial sponsors need it, we may jump to cardiac MRI to be able to prove to them that we think it's better than what's reading out at. As far as MUGA goes, it's still used. I think at Grady, it's used more frequently. It is certainly a good tool for patients. One of the downsides in MUGA has always been the radiation exposure. And so particularly patients on Herceptin, which is a HER2 agent, they often have to get assessments of their heart every 3 months. The feeling is that radiation exposure is potentially more than the benefit that you would get from MUGA. So in general, I'll tell you, in the community, MUGA is not really used as a first-line test anymore. It can be used again as a tiebreaker, but not really first line. I think the convenience of echo, the widespread availability of echo is really going to be the driving force that continues in the field. Ultimately, we've talked with some of the folks here in cardiothoracic imaging about creating a protocol for short cardiac MRIs, so kind of a 15, 20-minute cardiac MRI protocol that specifically looks at function and some other things for cardiotoxicity. So we're in the works for that, but I think that still has insurance issues and has protocol issues and has timing issues on the scanner that may make it a little harder. Abby's second question is, what specific heart failure meds have been tested in chemo-induced LV dysfunction? So the meds that have traditionally been tested, and there have been several trials, I didn't go into all of them in this talk, but there are trials like Manicor, there's trials like CESI-HF. Primarily, we use beta blockers, ARBs, spironolactone, and aldosterone antagonists have been tested, and recently SGLT2 inhibitors have been tested as well. the drugs we have in the armament for cardiology seem to work well. And it's this idea that, again, if you can catch it in time, you can help offload the heart and then potentially recover function. The tricky part, and we haven't been able to answer this as a community, is which drugs are the best in all of this, because we've tested each one individually. The difficulty in running the sequential trials that we've done in other cardiology areas is these patients are sicker. And so often they will not tolerate even multiple drugs on board. And so a lot of it has to do with really what the patient looks like, what their pressures are like, what their other comorbidities are like, and what they'll tolerate with everything on board. And that's really what we end up doing in clinic. I will say that I often like to use beta blockers the most, because I think, as Abhi knows as well, they have a really nice kind of comprehensive effect on the heart, particularly in some of these cancer patients who may end up with renal dysfunction if they're not eating or drinking well, and maybe ARBs are not as good, or spironolactone isn't as good. But we don't have a good answer as to which is preferred. But certainly it seems that the heart failure medications that have been tested, they all do seem to work in this population.
All right. And then Priya Kohli is asking, how do you approach cardiotoxic medications or chemo in patients with a depressed EF? Are they absolutely contraindicated from the get-go?
Yeah, also another great question. So I think the simple answer is no. They're not absolutely contraindicated. If I understand the question correctly, do you mean how do you approach cardiotoxic medications in patients? Okay, absolutely. Do you mean chemo is absolutely contraindicated?
Is like an anthracycline, for example. Absolutely.
Okay, yeah, sure. So what we do in these patients these are the classic patients that we see in clinic, right? And we help assess how much benefit do we think they'll gain from their anthracycline, and how much do we think we can protect their heart from the damage of the anthracycline. The answer to that question is 10 years ago, I think the answer would be it would be absolutely contraindicated. And what we've, I think, done as a field over the last 10 years is try to kind of put that upside down and say, hey, there are patients who really would benefit from this. And if we can protect their heart through it, it really would give them better outcomes. So those are the classic patients that I think I enjoy seeing the most, because it's kind of this risk benefit approach and trying to understand what does their heart look like, how much benefit are they going to get from their cancer treatment. I think some of that is education as well. We're a newer field, and so some of potentially the older oncologists or some other centers, they may say yes to that question, right? And say, well, I was always taught that you can't do it. And so I think that's what we're here for. And that's what centers like, Winship and other comprehensive centers, where if we can push the envelope, we can help these patients through all of this. So I think this idea that if you have a reduced EF and you can't get anything, I actually specifically tell my patients that if anyone ever tells you that, make sure you come and see us, because that's the population I think we can help the most with all of this.
That's actually really interesting too, because I thought the answer was going to be an absolute yes as well. Last question, in the couple of minutes we have. I think it's really very cool to see people like you kind of crossing fields, and I think bringing expertise from different specialties really is an incredible niche. How'd you get interested in this, and how'd this happen?
Yeah, it's a good question. I think I got actually interested when I was training. Immunotherapy was just coming out, and I was just kind of blown away with what the potential for immunotherapy was. I knew I always liked cardiology, but I really thought immunotherapy would be something new that would really take the world and help a lot of people. When I did my training, I was trying to figure out an area where I think I could make the most difference for people. I think I was very fortunate to go to the places that I went and be able to say, hey, if I had to pick, where do I think there's a gap in the care right now? And I think I saw this as a gap in care. I saw these patients that would come and bounce around, and they still bounce around before they come to us sometimes, and be able to talk to them with some level of knowledge on both sides, I think is really helpful and comforting to them. So I think from the way I got into it, from hopefully a lot of speakers tell you, perhaps it's by chance, perhaps it's by interest. I think you touched on probably the most interesting point of this field, is that both in our research discussions, I showed you data, the stuff we're doing in prostate cancer, both in the clinical interactions. I mean, this is such a fun field to be in, because you're learning something new every day. There's new drugs coming out every day, and you talk to colleagues that really give you a different perspective, right? We come from one side, they come from another side. And I think for hopefully the trainees on the call, that's one of the best parts of being at a place like Emory, right? Is you have so many smart people, doors are open, and you can really have these conversations that can be game changers for people. So it's really fun.
That's fantastic. We are really at the top of the hour. There's a couple more questions in the chat, but I think we're at the top of the hour, so I may sort of close the session out, and if the others want to stay on, that's good for me. But thank you so much for coming. This was really, really fascinating, and again, opened my eyes to a lot of yeah, I had a lot of the myths in my head that you described. So so thanks.
Absolutely. Thank you for having me.